Mhm. She's great. Hi, Anne.
I am. It's just me and Anne.
Welcome. Hi, Anne. Can you hear me?
Oh, they're on the same.
I sat next to her in Duluth the whole time.
Did you have your first phone call yet in the thing?
I see you, Paku. I think it's that or like a phone call. I didn't
I think we'll get started in just a few minutes, but we've got quite a few people who've RSVP'd who haven't logged in yet. So give us a few minutes and we'll get started.
Again, but Paku didn't get it.
We're all ignoring you.
Good, good.
Loud clock. This is the hardest part, I think. Mm-hmm.
Yep.
Loud sound good. Well, I think just in the interest of time, since we do just have an hour together, I'd like to welcome everybody, and we'll get started. And as new people come, we'll just find out who they are and keep going. My name's Rebecca Buller. You are participating in the Wayside Recovery Center ECHO. Actually, we call it the Wayside Women's Services ECHO because it's part of all of us and the work we do together. I'd like to start by asking folks to introduce themselves. You'll have to unmute yourself, and hopefully if you are able, I'm not seeing a lot of pictures, if you're sitting at your computer, make sure your camera is turned on or enabled, and then we can see you as well. So let's start with Chelsea, please.
Hey guys, Chelsea here from Mothers First, mental health professional on the team here.
Hi, Chelsea.
Hi, Chelsea.
Hi.
And Paku?
Hi, you guys hear me?
Yes.
Okay. I'm Paku. I'm a social worker for the Mothers First program.
Wonderful. Thank you. Anne?
Hi, everyone. I'm Anne. I'm also with the Mothers First program. I'm the new supervisor here.
Great. And that reminds me, since I can't see all of you, if you have others in the room with you, will you be sure that they introduce themselves as well so we can all know who's there? Great. Hi, Chelsea. And Nelda, can you unmute yourself?
It's the bottom lower left corner to unmute. I'm going to unmute Nelda. Okay, we unmuted you. Nelda, can you introduce yourself?
Oh.
Okay.
We'll come back
Maybe
to
she
Nelda.
stepped away.
And then it looks like, I don't know who 952-295-63.
101. You added it
101?
too, but yeah.
I added something. Anyway, who are you? Hello?
Hello?
Yes, hi. Welcome. Tell me who you are.
Yeah, okay. Sorry, I didn't think that was my number, but it could be. We have a phone system. We have a lot of different lines. So my name is Jared Boostrom. I'm the executive director at Progress Valley.
Oh, wonderful. Thank you for joining us. Is there
Thanks for having me.
Oh, is there anyone else there with you?
Just me today.
Great, great. Well, I am going to kind of basically get started, and then when we get to another good breaking point, we'll check in and see if anyone else has joined us and welcome them as well. And I'm going to turn things over to Jessie from Wayside and have her take us through the rest of our presentation.
Hi, I'm Jessie Everts from Wayside Recovery Center, Vice President of Clinical Programs here. And we're going to have a brief kind of didactic. I'm hoping it will be a little more interactive than maybe our normal just sort of presentation, because we're going to be talking about ethics, and it's so there's lots of good case examples we could probably all talk about to talk about where we've seen some ethical dilemmas in our work and what we've done to face them or work through them. So we're going to have Carmen Finn, who's the Senior Director of Treatment Services at Wayside, do a presentation on ethics, and you'll let us know if there's points you want us to discuss, and then we'll talk about a case that we have and then open it up hopefully for some feedback and any cases that you'd like to talk about as far as ethical issues in your work. So take it away, Finn. Finn is our kind of ethics guru at Wayside, among many other things, many other jobs she has, and she serves on the March Board of Ethics Board?
Ethics Committee.
The Ethics Committee for March, and so she's got a lot of great knowledge about this. Okay, we're going to set up her PowerPoint and then pass the controls over to her. So hold on with us just 1 minute while we get her PowerPoint started. All right. Nod if you can see your PowerPoint now, yeah? Are people seeing the PowerPoint? Yes, okay.
Thank you.
Thank you.
Well, thank you for having me. We're going to kind of talk about ethical care in behavioral health, specifically in substance use disorder treatment. Please jump in if you do have any questions as we go forward. There's a lot to cover in 20 minutes, and honestly, there's whole courses on ethics care and substance use disorder treatment, so we're obviously not going to be able to cover the whole gamut of what that means to provide ethical care. Hopefully, we'll hit on some highlights today. So the things we want to be able to do during this participation or presentation is we want to identify pertinent ethical principles in behavioral health, identify what a true ethical dilemma is. I think we're all familiar with people throwing around this term of it's an ethical dilemma, and we want to really be able to identify what a true ethical dilemma is. Introduction and utilization of a 7-step ethical decision-making model, and how you might want to introduce those to your teams, and how to utilize one and when you do have a true ethical dilemma. Understand common ethical considerations. So we'll talk about some common things that come up in terms of behavioral health and unique to behavioral health and substance use disorder treatment. And we're going to talk a bit about current organizational trends in behavioral health that are actually unethical or sometimes illegal, depending on what state you're in, and what we're seeing we want to watch out for as organizations or persons who work closely with substance use disorder treatment. So a lot to cover in 20 minutes, and please let me know if you have questions as we dive in. Nice riveting quote from William Penn here: right is right, even if everyone is against it, and wrong is wrong, even if everyone is for it. So ethical principles are in most of the ethical codes, whether you're a licensed social worker, whether you're a licensed marriage and family therapist, professional counselor. Ethical codes and ethical principles via organizations or state or federal are sort of based on these 5 principles. Generally, if you read these over, they're things you're really familiar with, like do no harm, honesty, and keeping commitments and trust, justice, fairness, client autonomy. And we're going to sort of talk about how these ethical principles show up in substance use disorder treatment, and how you can identify then if there's a dilemma based on these ethical principles. One great grid is this ethical principle screen. Hopefully you guys have a copy of these PowerPoints or can download them. I utilize this a lot with training staff. This really allows us to look at when we're bumping up against these ethical principles, what seems to be higher, because often with the true ethical dilemma, what you're running into with your staff is at what point do we need to compromise one of these principles in order to look at a higher level of principle. So autonomy and freedom here on this principle pyramid is higher than privacy and confidentiality. This is actually built into like a law where we're able to get emergency services in a real medical emergency, break somebody's client confidentiality, because in this case, we want to uphold protection of life above, for example, privacy and confidentiality. I've seen various versions of this pyramid, and so this is not hard and fast, but this is a great discussion and jumping off point for your teams if you're interested in presenting them something or having this present during case consultation or in team meetings to have a discussion when you bump up against a true ethical dilemma, and what would be the best case scenario moving forward for a team decision that you make. So I really enjoy this pyramid, and I think it's something to have close at hand when you're having these conversations with people. So then what is a true ethical dilemma? The first one is there actually is no choice to be made. So for example, if it's required that you provide informed consent to a client prior to treatment services, then the question of whether to provide informed consent is not an ethical dilemma. So just because you have a staff person that's uncomfortable with something doesn't necessarily indicate a dilemma. Another example that I run in frequently is mandated reporting. Newer clinicians may say, well, I really don't want to make this report because she told me in confidence and I'm really uncomfortable doing that. I wanna keep her privacy or confidentiality. In this case, there is no ethical dilemma because the law would say you're mandated to report. And so in that case, the client's confidentiality, again, looking at that pyramid that we just saw, is going to be secondary to following the law of mandated reporting. In this case, because of you're making that report due to the risk of harm, which is higher than confidentiality. So in that case, that's not a true ethical dilemma because there is no choice to be made because it's law. There must be different possible actions or choices governing the issue. So if obviously there is no other course of action that you can take, then it's not an ethical dilemma. And lastly, in a true ethical dilemma, no matter which action you choose to take, one of the governing ethical principles will be violated or compromised. And so there's no perfect choice, there's no perfect action, and there's no perfect solution. So oftentimes when I'm having these conversations with my team, it's like we're looking for plan C, and that's okay that it's not perfect. So in a true ethical dilemma, there is no perfect solution. So when you're actually in a true ethical dilemma, one of the things that can be really helpful for yourself and your team is to run through a 7-step guide to ethical decision making. This is an example of one. Davis created this. And at the end of this PowerPoint presentation, there is a resource link that you could get this particular decision-making model if you're interested in. I've seen many different kinds of decision-making models. There's a feminist decision-making model. There's one with far more cultural considerations. But this one I particularly like, particularly because of number 5 with the testing the options and it highlighting all the various ways to test the options. The one thing that I think is missing for me that makes most sense with me, and I would say is step 0 before step 1, is to breathe and taking a step back and just take a deep breath and ground yourself before you start working on these 7 steps. So the first step in a 7-step decision-making model is actually stating what the problem is. And for me, this is also where I'm helping my teams work through, is this a true ethical dilemma? Is there an issue here? Is there currently a law or something that's in place where this wouldn't be a dilemma? There actually is a clear choice here. And so we're going to state the problem so we're all aware of what that is. And then number 2 is checking the facts. So oftentimes when we're in a critical situation or in a true ethical dilemma, we're missing a lot of the facts. And with a little digging and getting more facts in place, it goes from speculation to, okay, we actually have a clear choice here now that we have more information, which dissolves the dilemma. So for example, when you look and you dig a little further and you're able to understand who the persons are involved, if there's any professional codes that dictate or practical restraints, you're able to sort of dissolve the dilemma. And number 3 is identify the relevant factors. This is where I often tell my staff to put in cultural considerations and look at the cultural component. Number 4 is develop a list of options. So this is where I say be imaginative, even if it's something that seems far-fetched or you think your team is just going to bat down. Really make sure that you have all options listed and try to be very imaginative. Try to avoid letting your team just say yes or no about something right away, or going with the first thing that somebody seems really excited about, and really challenge your team to take that extra 5 minutes to dig deep and try to find more options. Number 5, and this is my favorite part of this one, is actually testing the options. And so the first one is the harm test, asking yourself or the team, does this option do less harm than all the other alternatives you have written down? The publicity test, which is a fun one, would you be okay if the option that your team chooses or you choose is published in the morning newspaper, front headline? Would that be something that you'd be comfortable with? Defensibility test, could I defend my choice of this option before a congressional committee or committee of peers? So oftentimes this is where, too, you really want to cultivate good consulting relationships outside your organization, because a committee of peers doesn't necessarily mean a committee of those you already work with, because sometimes, especially after a couple of years, the team that you have it can lose touch with what's going on in the outside world in terms of behavioral health or new practices that have maybe been determined to be best practices. And so when I'm thinking committee of peers, I'm really looking at a committee of peers outside your organization in the same scope of practice as you. Reversibility test, would I still think this option was a good choice if I were adversely affected by it? So this is something that a team was deciding, and this was my life. Colleague test, what do my colleagues say when I describe my problem, suggest this option as my solution? The professional test, what might my profession's governing body for ethics say about this option? And the organizational test, what does my company's ethics offices or legal counsel say about this? If your organization doesn't have a legal counsel, this is something to start talking about in regards to organizational ethics. or where do you get legal counsel in regards to true ethical dilemmas? Number 6 is make the actual choice with you yourself or your team. And then number 7 is review the steps. How can you reduce the likelihood that you will need to make a similar decision again? Meaning, how can you make policies or procedures in your organization, provide additional staff training so that this dilemma doesn't reoccur, so that you can try to decrease the number of ethical dilemmas that are occurring in your organization or with your clients. So that's a 7-step guide to ethical decision making that can be really helpful, whether you're doing this in team building, you're having it pinned at your desk somewhere, so that when you're having a true ethical dilemma in regards to substance use disorder treatment or behavioral health, you can run through to really help you sort of make the best ethical decision possible. So in behavioral health, here are some common ethical issues and concepts personally that I hear about most. This is not an exhausted list, so we could absolutely discuss this more. One is scope of practice. Particularly as I see different sort of job roles be created in behavioral health, from peer recovery specialists to treatment coordinators. What does this look like for one group to be practicing within their scope? And I think that it's up to us as colleagues to learn what the scope of practice is outside of our own as well, to help each other in the organization as a team make sure that we're practicing within our scopes and that we're clearly able to communicate what is within the scope for a particular job role to our clients. Confidentiality, we're bound by federal regulations of substance use disorder treatment, which is CFR 42, so that's pretty strict standards of confidentiality, and both how are we describing that to the client, how do we make sure that we follow this stringently within our organizations. Oftentimes, though, we are bumping up against this issue. For example, what is a true medical emergency versus a perceived medical emergency in order to call medical personnel and break client confidentiality? How are we reporting that, documenting that? Mandated reporting laws, duty to warn. Boundaries, I think, is the one that probably comes up most in regards to actual license violations with like the Board of Behavioral Health and Therapy. If you review their statistics, the ones that people are getting their license suspended for are boundary violations, romantic relationships with clients and that sort of thing. So definitely improving where we're teaching boundaries to our new staff. How are we continuing to discuss that with our clinical staff, professional staff as organizations? And then informed consent is a big one that we don't really talk a lot about for some reason. I think the other ones get more time, but the client autonomy and transparency and justice are all tied around clients being informed every aspect of the treatment they're receiving, and not finding out aspects of their treatment, whether it's 4 weeks in outpatient or 3 weeks in residential care, or any other aspect, that they truly understand the risks and benefits of their treatment, what the scope of practice is and the different qualifications of the staff, who they're going to be working with, what does treatment look like, and that's clearly provided to the client in some form. And we talk about it being essential at the beginning of treatment, and how are we constantly informing them and doing informed consent throughout their treatment stay. So those are some common ethical issues and concepts that are seen and specific to behavioral health and substance use disorder treatment. So here are some current concerns that are coming up lately regards to ethical behavior. We are still working in really rather largely unregulated field. The other day I was trying to look up for a specific county about regulations for when a client can be discharged and how a client can be discharged from their housing when it's sober living. And unfortunately, there's rather limited regulation in regards to sober living in this particular county that I was looking up. And so as a field with substance use disorder treatment, there's a large part of the organizations that we work with that are unregulated. And so you're seeing lots of practices. And then even with those places that are heavily regulated, you're still seeing unethical practices that are very common that people aren't necessarily aware are necessarily unethical. So one that we're seeing time and time again, not as common in Minnesota, although we still see this. You may have heard this being a big issue in Florida. That's been in the news for the last 5 years, I think, is treatment centers paying per head for successful referrals or recruitments, often paying third parties money or gifts to send clients or recruit clients successfully into treatment. Excessive urinalysis and insurance billing practices. So this one is a lot more common right now in Minnesota, where organizations may be doing several urinalyses a week, despite the fact that many substances stay in your system 3 to 7 days. So there really isn't a need to be doing a urinalysis day after day after day, or several times a day for that matter, and then billing insurance companies in order to do that. So making sure that your clinicians are documenting why a lab is clinically relevant for a situation. And another one that is a little bit more common in Minnesota is that patients are rapidly moved through phases of treatment based on census rather than treatment readiness. And so this is a situation where you may have one aspect of your treatment, like medium intensity or low intensity or IOP or outpatient, that has an open bed, and so you're moving somebody from a higher phase of treatment to a lower phase of treatment because that bed is readily available and it's easier to recruit for your higher intensity, things like that. So that's actually an unethical practice. Another one is offering carrots to clients to come to your particular treatment. So we've seen where patients don't have insurance, and so some programs offer to sign you up for a policy and agree to pay your first month of insurance coverage. Another one is taking advantage of clients who don't have housing, and so some programs will pay for rent or utilities for the clients for their first month or a couple months, with the caveat that you have to go to their treatment services in order to get that rent or utilities paid. And so then that's butting up against client rights, where they are supposed to have their choice of provider when they're receiving services. Current concerns, more that we're seeing is, again, unregulated sober living, where there's actually overcrowded situations that aren't abiding by, there's even fire hazards related to them, and the amount of space somebody is supposed to have, what is actually a bedroom legally. And then one that I've recently learned about that I'm concerned about is patients turned recruiters. So in this case, you have alumni who the treatment is now hiring and will pay them finder's fees for recruiting people they know who are still using to go to treatment. And then you've got situations where alumni who weren't used to, first of all, maybe having a job, and now they're making lots of money bringing in their people that they know for treatment, and they're actually then doing things like, for example, splitting their finder fee with the people that they're then recruiting into treatment. Another thing called black hat marketing, where this is also something that I have seen in Minnesota. A lot of other states, though, have this going on a lot more, where places are actually overstating the services they're offering, or they used to have a service 3 years ago, they're not taking it off their website, and so clients are entering treatment thinking that, for example, they're going to be guaranteed housing, or that they're going to get case management, or all these other things that are actually overstated, and that the organization is not providing. So it's deceptive advertising practices. Another one for black hat marketing, which I'm not aware of in Minnesota, it's just something to be on people's radar, though, is treatment centers kind of using another more established treatment center's name in their advertising, or flipping phone numbers, things like that. So these are things that we are seeing, sort of trends of unethical or illegal behavior in the field of behavioral health, specific to substance use disorder treatment, that we're needing to be aware of and be concerned about as we move forward. When asked in a current behavioral health survey what was the most important factor to improve industry and public reputation about the substance use disorder industry, 25% of respondents said that we need to start shutting down unethical organizations. And another 25% said we need to improve patient outcomes. I would add to that we need to be asking people to be providing outcomes and publicize those. If you go onto most people's websites, their outcomes are not publicized, and people are not collecting that data. So it's not just improving patient outcomes, it's also having those outcomes be available for other people. So interesting thing that people are aware that the reputation for substance use disorder treatment it is a little bit, got a little bruised eye there, and that we need to be looking at things that we can do strategically in order to improve our reputation as an organization and a field. So if you have concerns about unethical concerns with substance use disorder treatment, certainly if it's an individual practitioner, you could go to their license board or state oversight. If it's an organization, oftentimes organizations are accredited, and you can go to a program accreditor like the Joint Commission or CARF. State Attorney General offices, if you notice that some of that black hat situations happening with fraudulent or criminal business practices. And then in the state of Minnesota with 245G licensed facilities, going to State Department or Health or Human Services or licensing agencies and reporting these issues that you might notice that are fraudulent or ethical concerns. So here's some resources that you can utilize and some references. And my contact information. I'm always open to consultation or questions that people have regarding ethical issues. I'm also part of the, as Jesse mentioned, the co-chair of the March Ethics Committee, and March has a great website that you can go on if you have a question that you just want quick feedback about. You can actually use a website to do a consultation for an ethics concern, and the Ethics Committee will get back to you generally within 48 hours. So, questions?
We've had several people join us during the presentation. I'm wondering if while people are kind of thinking through their concerns or questions or things that have come up that maybe Finn didn't mention, maybe we can go to the, you can show me down the list who the new people are and just have you say your name and what organization you're with. So I just want to see who we've got joining us. DJ Morris, can you let us know who you are? Unmute yourself in the bottom left and say who you are and where you're from. Someone under DJ Morris. See, people thought they weren't going to have to talk right now, and so I called them out. They're not prepared. We'll come back to DJ Morris. Brian Grahan, are you on? Can you introduce yourself?
What's that? Hennepin Healthcare.
Hi, Brian. Thanks for joining us. Scroll down a little bit further, James. Who else do we have? Jessica S. Can you unmute yourself and let us know who you are and where you're from?
Hi, I'm Jessica Sauter, and I'm from Wayside Family Treatment Center.
Oh, hi, Jessica. How are you? All right. Ken Roberts, can you unmute yourself? We unmuted Ken. Ken, can you introduce yourself? Okay. DJ Morris, are you back on with us?
Sam was up there.
How about Sam? Can you introduce yourself, Sam?
Sam Vitiello, House of Charity.
Welcome. Thanks for joining us. Okay, well, two others who maybe are not sitting at their computers right now are also have joined us since we started. And we'll open it up for a few just questions or comments around Finn's presentation on ethics. Were there things that came up for you either that you had questions about or kind of fit your experience or are different from your experience with some of those current concerns happening in substance use treatment? Any comments or questions? Okay.
Actually, could you just give an example? I know you kind of like get a laundry list, but even just of a specific patient example, because I think oftentimes there's things that are challenging, but like you said, it's not necessarily an ethical dilemma.
Mm.
I'm curious if you can offer an example of something that you've recently faced.
We are going to do a case in just a minute, but it's kind of around a systems issue. Can you think of any cases that fit some of your presentation?
I can't think of one recently that's like a true ethical dilemma, because honestly, a really true ethical dilemma doesn't happen very often. But I can give you something that kind of comes up that the staff often view as an ethical dilemma. Sometimes I'm director of a family treatment center, and sometimes we have situations where, for whatever reason, child protection has come to the place where a child is going to need to be removed while mom is in treatment with us. And we've had situations where, like, the child protection worker will say, I'm calling you to let you know that we're going to be by Thursday to pick up the child, and the child's going to enter foster care, and we do not want you to tell the client. So this butts up against those principles of client autonomy and being able to make decisions for themselves for treatment, but also transparency. And so the CP worker, for reasons, will often say, we're concerned the mother's going to flee once she knows with the child. And so the staff will often feel like it's an ethical dilemma, when in actuality, the choice would be, if we're looking at the facts, the child is not in immediate safety. If the child protection worker feels that the child has immediate safety risk, I would recommend that they send the sheriff immediately, because following my ethics as a clinician, I'm going to allow the client to have their own autonomy and also be transparent in what I know about them and their case. And so I would be informing the client that there's concerns from another entity, and that on Thursday they were going to come by and the child will be removed from the home, and what can we do in place to help the client in their treatment, because that's going to be obviously extremely hard for the client. And so issues like that when we're looking at all the facts, aren't necessarily a true ethical dilemma. We have Jesse's going to do kind of a case study that is about client advocacy that gets into some situation with some, I guess what would be more of a true ethical dilemma in terms of working with systems. But that's something that comes to my mind, that the staff are feeling really stressed with an instance like that, although I wouldn't necessarily think of it as a true ethical dilemma.
I was thinking too that one that comes up quite frequently is the tension between mandated reporting and HIPAA confidentiality laws. That at times those are opposed to each other, and we might be in a situation where we have to decide which of those is outranking the other, and that often poses an ethical dilemma, and one that usually there's some clear answer to whether confidentiality needs to be upheld if the client, and not in a child maltreatment situation, but in a vulnerable adult maltreatment situation. There may be times at which confidentiality laws outweigh our need to make a mandated report about vulnerable adult maltreatment. One that I can think of in my time at Wayside was a client who was a vulnerable adult living at one of our residential facilities, who went on a pass and was sexually assaulted, and returned to the treatment center and let us know about that. And she also said, I don't want this to be reported because I don't want this perpetrator to know where I am. And I don't want him to find out that I'm a client at Wayside. He'll know where I am then. And so we were posed with, she's asking us not to make a mandated report, something that would generally be a mandated report for vulnerable adult maltreatment. And in that case, we decided that her confidentiality as a client put her safety and in having confidentiality as a client outweighed our need to make that mandated report. And that is one that we've sort of been faced with by DHS, and that they would like a release signed for mandated reporting. And there are certainly times when clients are not willing to sign a release of information for us to make a mandated report. And in those cases, then we have to decide, does our requirement to make mandated reporting, is the safety of that client better upheld with a mandated report or by upholding HIPAA and confidentiality laws? So that's one that comes up not frequently, but at times that I feel like does put us in a true ethical dilemma, that we have to sort of decide what's the primary safety, what's going to uphold safety best between all of those ethical principles. Any questions or other situations, or were there other kind of cases that popped to mind to others that were on the call as far as client ethical issues that come up frequently for you in your different roles? Everybody's got their thinking faces on for you guys. I will go ahead with our case, and then maybe we can have some more discussion after that, because our case is a little different. It's not necessarily about a client ethical issue, but an issue of ours in providing care to a client. We had a client at our family treatment location last year who was a 32-year-old Hmong woman with, I believe, 2 minor children who were in child protection and were placed in foster care with a family member while she was with us in family treatment. Her diagnoses were amphetamine use disorder and cannabis use disorder, and she was with us for about three months or so, a little bit more than 3 months. And the purpose of her coming into treatment was really to be in adherence with her child protection case plan, and she was hoping to reunify with those children. And she was also trying to assist the family member, I believe it was her mother, who was taking care of her children, trying to assist her in getting licensed as a foster care provider for long-term care. But when she admitted to our program, she was already in the process of termination of parental rights, or TPR. That process had been started before she came in with us as a client. And she was aware of that process, had a worker assigned to her, and we had very little, we attempted a lot of contact with that worker who was assigned to her and didn't have a lot of success in terms of bringing that worker in for collateral meetings. This wasn't a worker who was requesting progress reports, so wasn't very involved in the care. And we began to find out throughout this woman's stay with us that they were actively pursuing the termination of parental rights. They weren't taking into consideration the fact that she was in treatment, in residential family treatments, with the hopes of reunifying with her child and making really excellent progress. She had all negative UAs while she was with us. She was absolutely treatment adherent, following a treatment plan, making all kinds of strides, and had a good discharge plan as far as going into sober living and outpatient treatment. That was all based on having some reunification with her children. However, the worker was not carrying that message to the courts or considering the movement that she was making in treatment as far as following her case plan. She was just pursuing the TPR. So the ethical dilemma for us became, I think, inclusive of a lot of issues, one of which is scope of practice. As Finn mentioned, we're a treatment provider. We're not legal aid for this client. We're not her child protection worker, and we felt it was really unjust what was being portrayed to the courts, or the motion that was being made against her, regardless of the fact that she was in treatment and doing really well. So the one of the ethical dilemmas that we were faced with was, do we get involved with this beyond our scope of practice as a treatment provider, and what does that look like? And at first it looked like helping that client advocate for herself, and we really tried that tactic for a good amount of time, trying to help empower her with her workers, and to make as much motion with updating the courts on her progress in treatment. And that there was a disconnect, and we don't to this day know what that was, whether the worker was not interested in knowing the facts of the case, or was not portraying those facts to the court. We don't know where the holdup was, but the fact that she wasn't able to advocate for herself in that case. So we got involved and had everyone up to our CEO in contact with the county workers who were involved in her child protection case, and talking about what ended up happening was that there was a sort of a system breakdown, in that the supervisors weren't aware of what kinds of progress reports the caseworker was submitting to the courts, and that she wasn't aware of how much progress this client was making, or that she had a solid discharge plan. And so our advocacy helped kind of connect those departments, and had the supervisor had to make some sort of authoritative decisions about communicating both to us and to the worker that was assigned that a TPR is a process and is not a decision made from square one, but is supposed to be reflective of how they're working a case plan and a process that can be undone. It's not a final decision from the start. So it was sort of a systems ethics dilemma that we found ourselves involved in and needed to step a little bit outside of our scope of practice in order to advocate for this client. And I don't know if Jess or Finn, if you want to add anything to that about kind of the facts of that case, or if we can also open it up to comments, questions.
I would love to add to that. I personally worked with this one. It does bring up a lot of feelings, so just so you guys are aware, it was a really hard case. One of the things that I really struggled with was discrimination. I felt that she had language barriers. They didn't have anyone working with her to make sure that her mother and her understood what was being communicated to her. So that was something that was really challenging for me. Paperwork was lost within the transference, so she had different caseworkers working with her, and there were things that she, for example, a parenting assessment she had completed and they say she wasn't completing. And so fortunately she kept copies of things to prove that she did do these things. So there, again, the lack of professionalism and stuff were things that we were being challenged with. And we did communicate to her supervisor. Her supervisor was on every email chain that we sent out. And so it was just, I think that maybe we could have communicated with the supervisor above the supervisor and so forth. So those were some things that I would add to that.
Mm-hmm. Thank you. Yeah, that's helpful.
And then she had 4 kids.
4, sorry.
That's okay.
Any other questions about that particular case, or kind of ways that translates to clients that you're working with, and either systems issues or ethical dilemmas that come across your desks or your minds frequently?
Well, frequently it's the struggle within the system for me, since we're talking about this case and I'm here. It's really the scope of what is my scope, having to ask myself, what can I do here? And having that acceptance of the fact that I can only do so much because some of the stuff is outside my scope. And so with that situation, it was, we did as much as we could to empower that individual and inform her of her rights, but outside that, we can't control the other systems. I mean, we can bring awareness to the system and the dysfunction, but when working with other systems, it's definitely a challenge to kind of that boundary that you were talking about, understanding boundaries and ethically what's an appropriate boundary for me when working with systems, so I'm not overstepping those boundaries in the system.
Yeah. Yeah, absolutely. And I think something you kind of mentioned, Jess, is so advocacy and empowering clients is within all of our job scopes. And I think sometimes that gets lost as far as throwing up our hands and saying, well, we can't do anything more without working outside of our scope, and seeing that there's always something that you can do to help advocate for a client, or especially when it's a system sort of failure outside of your system. Kind of advocating for clients and or empowering them to advocate for themselves is something that's within every job scope. It's never not part of our jobs. And so seeing that as something that we can do, and that sometimes we have to use our power as providers, or using some sort of authority in order to be able to advocate for clients if they're not able to advocate for themselves. I think that's always ethical.
And with this client, it was really difficult because this is one of the clients I really used feminist theory with. What else did I use with her? I use a lot of feminist theory for sure, and narrative to help empower her, to kind of help her explore that. But she was so worried about how it would impact her CPS worker. She was worried about her CPS worker getting in trouble. And so filing agreements, talking to the supervisor. Those were things she didn't really want to do because she was worried about the CPS worker losing her nut job. She didn't worry about her children losing her job. Well, she was worried about losing her children, but helping her to kind of explore what the choices that the CPS worker was making and how that was impacting what was happening with her children. That was really a big struggle because you had to kind of look at the boundaries and making sure that you're not letting her, you want to help her find that on her own and help her process that and work through it without being like, don't you realize that this lady doesn't seem to care that you're not going to have your children? She doesn't, you know what I mean? And so that was another boundary and line that was really difficult with working with this system. Working in that scope of practice and the boundaries within the theories that we're utilizing.
Yeah, I think that applies to so many of the situations that Finn went through that are sort of unethical practices that are out there that clients might not see as unethical. I mean, they might see it as, this is what I have to do to get housing, or this is what I have to do to get money. And so some of it too is training them to be advocates for themselves and to recognize their rights and recognize when somebody might be infringing on their rights, that's a duty of ours as well, is to not ignore an ethical dilemma just because a client doesn't see what's unethical about it, so that we're bound to act by that, even if they're not feeling like that's something that they want to do, that we might need to do that instead. Closing comments or questions?
Well, I'm so glad that you have all joined us. And a couple things I want to remind you about. You will be getting an evaluation, and if you would send it back, that's very helpful to us. We really need those. I think we've captured all the attendance, and so we're good there. If you have ideas about future ECHO topics, I'm putting together the rest of this year and 2019 schedule. And the exciting thing is that starting in September, we're going to go to twice a month. So both the first and third Thursdays over lunch. Everyone's invited. Don't worry about whether you're eating on camera. We do that. And it's really about, finding the time to share and network and get the information throughout a larger network of people. I want to also stress that you can invite colleagues to join us. And if it's helpful, I will come out and talk to small groups of people. If you have a network of professionals that get together, I'd be happy to come and explain what an ECHO is and how it can be beneficial and how they can also be a participant in more than observing, but a real active participant in this process. And I want to remind everyone that we did send out the PowerPoints presentation for this session, but we post them all on our website at waysiderecovery.org. And if you go to the professionals tab and pull down to ECHO, you can get the agenda, the recording of the session, and any handouts or presentation materials that we have available. So you can always go back and check out what's happened in the past or pick something up if you happen to miss a session. Our next session is September 6th, and the topic is to be announced, but I will try to get it to you as soon as I have that information, and do welcome your suggestions as well. Does anyone have any further questions or concerns or ideas that they want to share today? Well, then have a wonderful summer day.
Thanks for
It's
joining
cool
us.
today. It's going to get hotter this weekend, so drink lots of water and take care of yourselves.
Thanks, everybody.
Bye-bye.